Perfect. All right. Welcome back, everyone. I see there are a lot of you here, and hopefully you all had a nice lunch break for your first day here. It's a lot of material, and so welcome to the second part of today, the afternoon session. My talk, I have you for 3 hours, and as you can see the schedule that we have 3 different topics now. Not all of them will be exactly 1 hour. It'll kind of depend based on how this goes with your questions and with the content that we have here. I'm Andrew Wu. I've been teaching the Oslers for a while now, since actually about 2013. So, and this is for the written exam here. And as you can imagine, there's a lot of topics to get through the next 5 or so days. And so we have to really be strategic in what we present with example questions so that you'll have the best bang for the buck in terms of the test itself. So hopefully the first set of trauma lectures went well. There are some overlap, and we do our best as faculty members to try and not repeat things, but give you all new material for any of the topics that kind of crosses over. So I am a surgeon. I do all types of surgery, general trauma, bariatrics. That is my specialty and foregut, but I do all types of surgery here in Manchester, New Hampshire, which is an hour north of Boston, sandwiched between an hour south of Dartmouth. So. And we're going to start off today with minimally invasive and metabolic surgery. If you have any questions, as was discussed with our team, you can ask any questions in the chat function. And with that, we will proceed. All right, so intro to MIS. So you're all a part of this, but certainly in the last decade or so, 15 years, there's been an exponential increase in the drive and development of minimally invasive surgery and technology that includes endoscopic technology, robotic technology. And that's because of a drive for increase in safety, patient outcomes. All this is due to smaller incisions, quicker recovery times, decreasing length of hospital stay. And our goal is to decrease the trauma for the patient while achieving overall goal of the surgical operation. So essential principles of laparoscopy. We're going to talk about gaining entry, and we'll have some select videos here for you to enjoy and comment on. And actually, Mike had just told us to select a different laser pointer. So hopefully this laser pointer works here. All right, so our goals are to obtain safe access into the abdomen, establish a pneumoperitoneum with a 12 to 50 millimeters of mercury pressure using CO2, Trocar placement under direct vision, triangulating the organ to be operated on, always be prepared to proceed to an open procedure, and always be cognizant of the physiologic effects of laparoscopy on the body. All right, so I'm gonna try to make this interactive for you all. Obviously, we're not here live in front of you, but in your mind, feel free to think of what answer you'd have. You don't have to chat that, otherwise our chats would be flooded with answers. But these are just representative questions for you as we go through and navigate this talk. Which of the following conditions represents a contraindication to advanced laparoscopic operations? Pregnancy, B, morbid obesity, C, contraindication to general anesthesia, D, previous laparotomy, and E, cirrhosis. All right, C, contraindication to general anesthesia. All right, so contraindications, high-risk ASA4, not ideal candidates. They may not tolerate pneumoperitoneum. Previous contraindications, morbid obesity, previous abdominal surgery, pregnancy, and early cirrhosis. All right, so let's hope that these videos work. I did test them the other day. So abdominal entry. Take a look at how this surgeon approaches abdominal entry. And in your mind, think about, is this the correct way of doing it? Is this how you do it? Is this how you were trained to do it? What would you do differently? I'm going to play this here for you all. You know, towel clamp lifting up, Varus needle. Those are the number of settings here. Liters and flow, millimeters of mercury. Okay, you've got a Varus needle here, midline. All right, there you go. So maybe some of you have performed or currently obtain entry that way. Maybe some of you don't. Maybe some of you do a version of this. If you all think that this is the absolute safest way of getting entry, I'd say that you're incorrect. There are a lot of things that can be done differently for a safer entry here. So, all right, so which of the following is not an appropriate technique for initial trocar placement during laparoscopy? Is it Varus needle insufflation followed by blind trocar placement done in this case? open placement of a Hassan cannula without pneumoperineum. C, optical trocar placement. D, blind trocar placement without pneumoperineum. Or E, all of the above are acceptable. So think about which answer you'd have here. All right, it's D, blind trocar placement without pneumoperitoneum. So getting access to the abdomen. So there's really two types, open and closed. If it's closed access, you have varus needle, then blind trocar, varus needle, then optical, no varus and optical, no varus and blind. In open access, it's cut down to the open fascia Hassan trocar. Now you can sit here and argue with others about which one is the best. Technically, out of all this, there is really, and you might think one is better than the other, but there's really one that for sure cannot be done, which is no varus and blind trocar insertion. That is the most unsafe. So historically, varus needle, 12 to 15 centimeters long, not meters, spring-loaded inner stylet with a beveled needle point, tip is dull, first described in 1938. Interestingly enough, Hungarian internist working with TB patients, originally designed to induce pneumothorax, collapsing the infected lung to allow lesions to heal, popularized after the 1980s. Always consider patient anatomy and past surgical history. Decompress the stomach with an NG tube. Ideal location is umbilicus. Abdominal wall is thin and the umbilicus is tethered to the fascia. You must tent up the fascia with the clamp before entry. And keep in mind that that's not the ideal location, but that is an ideal location. From the surgical training perspective, I'm sure that most of us here have been taught that the ideal location would be the left upper quadrant of the abdomen, Palmer's point, 3 centimeters below the middle of the left costal margin. So all the more important reason to have a desufflated stomach. The stomach is thick and can sustain damage if the varus needle does penetrate deep,